Your eyes are directly connected to your brain's blood supply. That means a routine eye exam can reveal dangerous changes in blood flow long before major stroke happens. Dr. Anna Rosa explains the eye-brain connection that can protect your life.
The new technology now allows eye doctors to detect early warning signs of vascular disease, often before symptoms appear. So we're talking about stroke, we're talking about stroke prevention. Using a simple, non-invasive test called optodynometry, or what we call ODM for short, we can measure retinal artery pressure and uncover hidden risks to the brain and the heart. Today, we will explore how this breakthrough is connecting eye health to brain health, and how collaboration between eye doctors and radiologists using carotid ultrasound and transcranial Doppler ultrasound may help prevent strokes before they happen. Joining me is return guest Dr. Anna Claudia Rosa. She's a radiologist, she's an MD, a PhD, and an expert in neurovascular imaging and stroke prevention. Together, we'll uncover how the eye may become medicine's newest window to saving lives. Dr. Rosa, thank you for joining me again today on the Dr. Kerry Gelb Open Your Eyes podcast.
Thank you so much to you, Dr. Gelb, for having me here again. I am so honored to speak to your audience, especially about something that connects ophthalmology and radiology in a way that we could prevent major events together.
You know, one of the things as physicians that we like to do, what we want to do, and that we have an oath to do, is really to prevent disease. So a lot is talk about preventing heart attacks, preventing cancer, preventing different types of blindness, but we don't talk a lot about preventing stroke. And here's a way where we could connect the eye, where the eye gives us clues to help us with clues to see if somebody's at risk for a stroke. Now, you're a radiologist, you know about all the radiologic tests. Tell us about the carotid ultrasound and why that's an important test.
Carotid ultrasound, it's a very important test because it evaluates the arteries that go from your neck, branching to the arteries that go to your brain. So we can evaluate the internal carotid artery, which is one major origin for arteries in your brain, and for your especially for your specialty, particularly the ophthalmic artery. And we could evaluate the vertebral artery, which is the posterior circulation in your brain, and we can evaluate the external carotid artery. So it's very important because the Doppler ultrasound of the carotid allows us to see the vessel diameter, if there is any formation of plaque and stenosis. The degree of stenosis predicts risk for stroke and indicates necessity for treatment, such as revascularization. But also, the carotid ultrasound allows us to see the direction of flow, the resistance of flow that shows like stenosis and turbulence, and mainly two factors that are very important to be evaluated, particularly for prediction of disease and progression of disease, which is the intima media thickness criteria, and also the formation of the plaque. Since the beginning, when it's soft tissue plaque, and it could become unstable, and it could become ulcerated with greater risk of embolic stroke, and later on, the more stable calcified plaque that leads to narrowing and resistance in the flow.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. So when we're looking at the carotid artery and we're looking at plaque with ultrasound, how does that differ from carotid IMT? And which one is better for helping us to determine who's at greater risk for stroke? Now, both of them are used, but is there one that's better than the other? And do they tell us different things?
So as a radiologist, when I get an exam, I don't really get the separated like carotid intima media thickness measurement or the carotid ultrasound that evaluates everything, right? So the first thing is you could measure the carotid intima media thickness, which is the IMT, and it's measured in the common carotid artery, 2 centimeters before the carotid bifurcation into internal and external carotid artery. The intima media thickness is a very important prognosis factor because when it starts getting thicker, it is a sign that atherosclerosis disease is in progress. It is a sign of endothelial dysfunction, inflammation. It is your neck whispering, I'm getting damaged here. So intimal media thickness is normal when it's up to 0.8, less than 0.9 millimeters. When it is in between 0.9 and 1 millimeter, it is borderline. And when it's greater than 1 millimeter, it shows that it has increased risk for stroke. So why is it important? Because it's the first sign that we can see with ultrasound that we have that the person is having the endothelial lesion, endothelial injury, and will predict progression for vascular disease, progressing to soft tissue plaque, ulcerated, unstable, and calcification. And then the carotid Doppler ultrasound becomes more complete when after we measure the intima media thickness in the common carotid artery, then we are going to evaluate soft tissue plaque, morphology, location, and then calcified plaque, morphology, location, and then with specific angles, we evaluate the waveform that shows if there is resistance, if there is narrowing, and velocity criteria that allows us to degree the grade of stenosis that is important.
Dr. Falk, who's an ophthalmologist in Connecticut, developed an easy way to measure the central retinal artery to tell us if somebody's at risk for stroke by doing a simple test during an eye exam. And now, since the internal carotid shares a common origin with the eye and with the brain, we're able to pick up if somebody's at risk for a stroke, and then further testing could be done where we could test the common carotid, or we could test or do transcranial Doppler. And I just think this is a wonderful way that a very simple, fast test in the eye doctor's office. Dr. Falk's his research shows that between 75 and there's a 78% chance if that test in the eye doctor is abnormal, if there's going to be it's going to be abnormal either in the carotid artery or the transcranial Doppler will be abnormal, and we could save people's lives and save people from getting paralyzed from a stroke. And if you could just comment on that. I know it's very complicated. This is a very complicated topic because a lot of people aren't used to it, but it can be made in a simple way because we're just dealing with certain blood vessels and we're dealing with, we break it down, we're dealing with plaquing, whether it's soft plaque or calcified plaque in the blood vessels. And then we're going to talk later about certain treatments that could be done for prevention.
Yes, so absolutely. I love this because everybody should have an eye exam at least once a year, right? And some people should have it even more frequently. Like I have my eye exam every 6 months because I have significant eye issue. But anyway, it's very important that you go to your eye doctor and you do an exam and you do the ODM. And then your eye doctor is able to look at your retinal artery. And on that, you could see microaneurysms. You could see decreased artery diameter. You could see decreased flow in the artery. You could see dilation of the veins, right? You could see abnormal capillaries, which are the small vessels on the eyes. And all of them correlate with what's happening in your brain. Why? Because the ophthalmic artery is the first branch of the internal carotid artery. And the retinal artery comes from the ophthalmic artery. So, and the origin, the embryology, the anatomy, the physiology, the way of regulation in circulation from the arteries of your eye, the ophthalmic artery, the choroidal artery, the retinal arteries, they have the same, they come from the brain. They have the similar vascular formation in embryology, anatomy, physiology, and ways of autoregulation. So when you see something happening in your eye, most likely you are going to have, most definitely, there will be something happening in your brain that is very similar, which could be stenosis, increased resistance, or soft tissue plaque in the carotid, or microemboli, or microvascular disease, or increased intracranial pressure. So that's a correlation between what you're seeing in your eye. Your eye tells what's going on in your brain, and then you could get evaluated. So the eye tells the story, radiology maps the road. Radiology evaluates what's going on from your heart until your brain, right? The aorta, the heart, the carotid arteries, the ophthalmic arteries, and the intracranial brain vasculature.
And I think it can't be emphasized enough and we've said it a number of times already, but the internal carotid artery is a common origin to the eye and to the brain. So that's why if there's a problem with the vessels in the eye, there could be a problem with the blood vessels in the brain. And
Yes.
it just can't be emphasized enough. So
Yeah.
now what happens? So if we get normal in one eye, where we have normal perfusion on the ODM of the central retinal artery, which seeing that is normal. But then we measure the ODM on the other eye, and that is way abnormal. And my understanding is that many times that could be carotid artery disease, and that's coming from the common carotid. And if you could make a comment on that.
Yes. So the findings on the ODM that should indicate the need for having additional evaluation with imaging would be, like you said, asymmetric findings between one eye and the other, or microaneurysms, or decreased blood flow, or increased resistance, or alteration in your capillaries and venous dilation and artery stenosis. So when you have any of these findings, it's very important to proceed and do the first exam. The first exam would be the carotid Doppler ultrasound. It's easy, it's accessible, and it gives information of the extracranial arteries that branch to your brain. So you're going to evaluate the common carotid artery, the internal carotid artery, and the vertebral arteries. What do we evaluate? We evaluate diameter. We evaluate, again, intimal media thickness, or IMT, which is a precursor, a predictive of initial beginning of disease of endothelial dysfunction, and progresses, gives us a prediction that we need to do something to avoid progression. And then we could see soft tissue plaques, which are unstable. And we could see on the soft tissue plaques if they are irregular or ulcerated, which become even more unstable, with risk of releasing fragments to the brain with the microemboli that could lead to a major stroke. And we could have calcified, more stable plaques. However, that would be leading to degree of stenosis that would also be predictive of major events such as stroke when the narrowing and the velocities suggest being greater than 70%. It is important to remember, though, that even when you have greater stenosis, it could be less important than if you have a plaque that does not give much stenosis but is unstable. So it is very important to evaluate the morphology. If the plaque is alive, like if the plaque is soft, if the plaque is irregular, if the plaque is ulcerated. So it's very important. So if the carotid we see structure, we see morphology, we see plaque and different forms of plaque, we see unstable plaques, we see spectral waveforms and velocities dictating the narrowing and the stenosis. And then after you do the carotid Doppler ultrasound, if there is any abnormal finding, you would proceed with transcranial Doppler for intracerebral circulation, which is more dynamic, which is like functional, how the brain is being perfused. And later, if needed, you could do a CTA or an MRA of the head and neck arteries that will also allow evaluation of the aortic arch and the origin of the vessels, because sometimes the stenosis could be more proximal instead of more distal. And the findings in the imaging exams will suggest that as well.
And is there a relationship between the coronary artery calcium score and the calcium that we may find in the carotid artery?
I would infer, I don't know about a specific correlation like in percentage of patients. I have not looked at this data, but definitely I would say that it's a vascular disease, it's endothelial dysfunction, it's endothelial damage, progressing from soft tissue plaque until calcification. So if you have calcified plaques in your heart, most definitely the chances of you having calcified plaques inside your brain, calcified plaques in your neck, calcified plaques in your aorta, either in the chest or the abdomen, and calcified plaques in your extremities, particularly the lower legs, leading to claudication or sometimes even erectile dysfunction. So it would be calcified arteries throughout your whole body. Yes, peripheral vascular disease, cardiovascular disease, cerebrovascular disease are definitely linked because they come from inflammation, they come from coagulation cascade activation, insulin resistance, diabetes, visceral fat, all the things that we are always talking, right? Diabetes, hypertension, they are all linked. Yes.
Since you brought that up, and so what kind of diet, what kind of foods do you think lead to putting people at risk for stroke and cardiovascular disease?
Definitely food and diet that is linked to inflammation in your body. That would be linked to fat surrounding your heart, fat surrounding your vessels, fat in the abdomen, which is the visceral fat. So the food that is linked to inflammation, which you should eliminate. So eliminate all processed foods, all ultra processed foods, sugar, alcohol, smoke, drugs, vape. Eliminate to the maximum carbs. You want to eat low carbs. Carbs are really not needed for our bodies, right? And definitely start moving your body with walking, particularly after meals, 15 to 20 minutes, that you can decrease the blood spike, blood sugar spike, the blood insulin spike, decreasing cortisol, decreasing inflammation. Definitely work on your sleep, work on balancing your circadian rhythm responsible for your sleep through the pineal gland, melatonin, and sun exposure. And exercise for muscle, for bones, for memory, for decreasing inflammation, strength training, high intensity exercises to decrease stress, and other things that decrease stress as well. Everything that decreases stress decrease your risk of stroke because decreases blood pressure, decreases inflammation, decreases cortisol. So journaling, gratitude, meditation, connection, community, what else? Sauna, cold showers, everything that makes you feel good with yourself and makes you feel in contact with you and the people you love. Yes.
And are you a fan of fasting? Do you think it's helpful for some people?
Yes, I forgot about fasting. Imagine that. I am definitely a fan of fasting, and there are different windows for fasting. So different windows lead to different results. Like longer fasting is really, really good for your immune system. Shorter fastings, like at 12 hours, 24 hours, already take away the sugar from your body. So yes, I am a big fan of fasting, either intermittent fasting or extended fasting, according to not making it overwhelming. So if you start and you are feeling sluggish, you are feeling weak, try drinking your water with your electrolytes. If you do not get better, you interrupt your fasting with protein, and then you experiment again later on, slowly but surely, so you don't hurt yourself and you don't give up on the strategy. But definitely fasting is great because it decreases your blood sugar. It helps your body reset insulin sensitivity, and which is important for inflammation, and decreases cortisol. And yes, absolutely.
And some people, they don't eat all day, they fast all day, and then they eat, and then they go to bed. To me, that's a diet for getting fat. You know, I think if you're going to fast, I think it works better if you eat in the morning and then not eat dinner, if you're going to do that type of fast. I was wondering what you think about that.
Absolutely. There are new studies showing, this is a great question. There are new studies showing that fasting should be kind of linked to your circadian rhythm. So like you would do your last meal, even if you're not fasting, if it's a normal day, you would work on having your last meal before the sunset. And then you would start fasting if you would like to fast, and then you would interrupt. I don't know how many hours you would like to do a fasting, but your first meal would be in the late morning or beginning of the afternoon, and that would be protein rich. And then if you would like to do only one meal a day, that's okay. If you feel you need a little bit more, you could leave it for a shorter meal later on, but that would be before the sunset, because definitely helps with your sleep, because when you don't have heavy meals, you don't have the blood sugar spike. So it improves your deep sleep, and the deep sleep is really important for cleansing your brain. The lymphatic system is working, right? So it's cleaning your brain from amyloid and tau proteins that are related to Alzheimer's. Is also decreasing the oxidative stress in your mitochondria, which is the cell that gives energy for all your body. So deep sleep is really important. It's healing your body, increasing growth hormone, decreasing cortisol, decreasing blood sugar, decreasing insulin, regeneration of cells, of muscles and bones, and improving your immune system. So deep sleep benefits from the sun and benefits from earlier meals. And also the REM sleep, which is like, for me, deep sleep heals your body. The REM sleep, or rapid eye movement when you're having your dreams, heals your mind. So the REM sleep is when you are processing meaning, processing emotions, processing information, neuroplasticity, and getting your memories. And both of them are benefited by the sun, by eating earlier, less heavy meals, and decreasing the temperature of your body when you go to bed, a cool shower, and decreasing the temperature of your bedroom as well.
You know, we're worried as doctors, as people get older, of sarcopenia, losing muscle. When people lose enough muscle, that's when they die, typically. Uh, because of that, do you have a protein recommendation that you feel that people should eat as they get older?
So that's a gray line because some people would have chronic kidney disease, and I would rather these people definitely check with their providers because there are people who have restrictions from protein due to kidney problems. And I know that it also varies regarding your level of body activity. So, like if you are sedentary, you might need less protein. If you are more active, you might need more protein. I do have around 1.5 to 2 grams of protein for my body. I usually eat 120 grams to 150 grams of protein daily. But again, I do not have kidney problems, and I have been more active these days. So I do my strength training, I walk every day, and I make sure that my first meal of the day always is protein rich. Why do you have protein? Because it is the muscle source of it's what the muscle needs to it's what the body needs to build muscle, right? So it's very important to have protein. It's very important. The main nutrient you should be the main macronutrient you should worry if you are counting calories or if you're counting carbs or if you're counting fat. Definitely is your protein. You should always reach your protein, and you should always aim for low carbs, less than 50 or less than 25 for low carb or keto. And yes, the protein is very important for your muscle production. And then I add my creatine. But again, creatine is also important to check with your kidney doctor if you have kidney problems. But I do have my creatine in the beginning of the morning to help with my muscles and to help with my brain cognition and memory and all this. Yes.
Yes, and as Dr. Rosa said, please, whatever we say, check with your doctor, uh, because what we're talking about may not be right for everybody. So
Yes.
talking about 120 grams of protein, 150 grams, that's a lot. So how much protein is in it? What will you eat? Will you eat steak? Will you eat chicken? To get your protein, how much protein is in a steak or a chicken breast? And on average, would you say?
I do have like 30 grams of protein could be seen. Oh man, I have the chart. I don't remember very well, but because I don't measure much anymore. But like I usually eat like 8 ounces of meat, and then later on, and I mix with eggs. So 6 eggs have 30 grams of protein. That I'm sure. And I usually also complement when I don't get all my protein in food that I'm chewing. I usually complement with a good quality of natural yogurt without sugar. And I get some protein powder of good quality too, that it's usually like grass-fed, grass-finished protein powder slash collagen. I know that's not the best, but when I am not able to eat all the protein in food, I complement a little bit with the protein powder. But there are some charts that people could Google and they would find like pictures explaining exactly. But the eggs I know for sure because I eat lots of eggs. 6 eggs are 30 grams of protein. Yes.
Oh, that's great. So we're going to get back to the radiology. We're going to talk a little bit about health and diet at the end. We talked about it now. I just want to review because, and I don't mind taking a little break from the complicated part, but I just want to review. So the ODM is something that the eye doctor does, and it's a non-invasive test. It's a very quick test, and it measures the central retinal artery pressure and tells us if you may be at risk for a stroke for the blood vessels in the brain. So then we talked a little bit about the carotid artery, measuring the carotid artery, and that is a very big predictor of somebody's going to have a stroke or a cardiovascular event. So now but we know that if the carotid artery is normal, that doesn't mean you're out of the woods. So that brings us to the transcranial Doppler, the TCD. So let's talk about that. That could be about 20 different tests that is done by the radiology technician, that the information goes to the radiologist like Dr. Rosa to evaluate. And of course, sometimes some of the vessels are missed. So even if it comes back normal, it's not 100%, but at least it's better than us finding something during the test. So let's talk about the transcranial Doppler ultrasound. What is it? What does it do? And then we're going to go through the key parameters very meticulously, one by one. Well, I'll ask you each one for you to explain. But let's start off because this is a very complicated topic, even for physicians. So what is a transcranial Doppler? This is going to be new to a lot of doctors, a lot of physicians, because we didn't always have technology now where the eye doctor could say you're at risk for possible stroke, where you can need these secondary tests. So please tell us what the transcranial Doppler is. We did the carotid ultrasound. Now we move to the transcranial Doppler.
So again, just a brief review. Carotid is a structure. You are looking at the diameter, the plaque, morphology, soft, ulcerated, irregular, calcified, degree of stenosis, waveform, and velocities. And they all give us criteria in saying that there is, like greater or equal 70%. It's when you are most likely in need of having revascularization according to the NASCET criteria. So that's carotid. And then we go to the transcranial Doppler ultrasound, which is a non-invasive exam as well, such as the carotid Doppler ultrasound. And it uses a pulsed Doppler that is low frequency, 2 megahertz. And you have windows in your head that will allow for us to evaluate the arteries. Again, transcranial Doppler is evaluating the intracranial arteries, the intracerebral arteries. So through the temporal window, you can evaluate the middle cerebral artery, which is the most important, usually evaluated. And then you can evaluate the anterior cerebral artery portions, right? And the posterior cerebral artery. Through the orbital window, you can evaluate the ophthalmic artery and the intracranial portion of the internal carotid artery that has an S shape called the siphon, and it's close to the cavernous sinus, close to the pituitary gland. And then you have the suboccipital window, which is here at the base of the skull in the middle line, the foramen magnum. And that's when you check the posterior cerebral artery and the vertebral arteries and the basilar artery. And then you have the submandibular, where you're going to check a portion of the internal carotid artery. And it's very important because if you have abnormal values, you're going to correlate the velocity from the middle cerebral artery divided by the velocity of the internal carotid artery, and you're going to throw the values in a ratio that's called Lindegard ratio that is important. We're going to get there. So anyway, the transcranial Doppler is a functional dynamic exam, different from the carotid that is evaluating anatomy, structure, degree of stenosis. The transcranial Doppler is evaluating direction of flow, velocity, resistance, through pulsatility index, through waveform characteristics and patterns. And so it's more dynamic. It's showing how well your brain is being perfused. So velocity, direction of flow, resistance, and waveform patterns. And the transcranial Doppler is really, really good too to check for microembolies, like which is called high intensity. It's a HITS test, high intensity. I forgot the T word, but the microembolies give noise, and you can listen to your brain screaming, I am not doing well, I am not doing well, right? By the chirps and the pings. And it's definitely a risk of, is a predictor of a major event such as a stroke. And the microembolies, they could happen even when you have a normal carotid Doppler ultrasound, because the microembolies could be coming from other sources. They could be coming from the aortic arch. They could be coming from the heart when you have atrial fibrillation, which has become so common due to the inflammation in the population these days. And it would also come from something more not very common, which is patent foramen ovale, when you have an opening between the atria, and when you have a clot, the clot could move to your brain and give a microemboli, microclot signal as well. And another thing is when you also could do transcranial Doppler when you are having procedures, like when you are doing a surgery for endarterectomy or carotid stent, you are monitoring if there are some emboli being released. And also embolies are very common as well, not only in people who have atrial fibrillation, which is a heart problem, but people who have prosthetic cardiac valves, right? Because some thrombi, some emboli could form along the prostheses that are metallic or not, and they could release, they could separate, and then could go to your brain. Not necessarily provoking a major stroke, but that's what the TCD would say you are having microstrokes, microinfarcts with the microemboli getting to your brain. Yes.
All these cerebral arteries connected, they call them the circle of Willis. Is that correct? So everybody knows
Yes.
of Willis. So let's take these key parameters one at a time. And you gave a very good overview, but let's talk about the mean flow velocity. So that's something that the radiologists term use. For laymen, it's the speed of the blood moving through the blood vessels. Let's take that one first. Now, which can be surprising to people, if the velocity is too fast, that could mean there's a problem. And if the velocity is too slow, it could mean there's a problem. So if you could talk about the blood flow through the blood vessels and start with the blood vessel, the blood going too fast. And what would be kind of a normal, I guess, somewhere between 40 and 80 is normal, somewhere around that. But if it's over 120, then it really becomes abnormal. Uh, so,
Yes.
so tell us about why this flow velocity is important and what we could learn about it if it's too fast, if it's too slow.
If we are using mean flow velocity, which is like I said, the velocity of the blood flowing in your neck to your brain or already inside your brain, what causes the increase in velocity is usually like when you have a distal stenosis. So let's think like you are driving, right? You are driving and then there is a narrow, and at that narrowing is when you have an increase in your velocity because it's really hard for you to pass that point. So increase in velocities mean that you have an obstruction beyond that point, right? And decrease in velocity is that you have an obstruction that was before the area that you are evaluating. So let's see if I can explain. Suppose you have and there are criteria for velocities. For example, for the neck, for the internal carotid arteries, we use a consensus from the Society of Radiology in ultrasound that is based on the NASCET criteria. And you like if the velocity is less than 125, it's normal. If the velocity is in between 125 to 230 centimeters per second, we consider 50 to 69% stenosis. Up to these levels, the management would be more clinical, which is lifestyle changes, right? And controlling hypertension. When you get to a velocity greater than 230 centimeters per second in the internal carotid artery, that's when you consider significant stenosis because you are having like greater or equal 70% stenosis. And that's when, by the NASCET criteria, they verified that the increased risk of stroke is significant, and they usually send these patients for treatment with revascularization. However, you could have low velocities and still be due to high stenosis when you are going to look at the waveform. So that's why you don't only look for one criteria. Like if I have a low velocity in the mid-internal carotid artery, and I would only consider the velocity criteria, I would say it's normal. But when I look at the waveform pattern, I am able to infer something's happening here. So the waveform normal is a high upstroke, a high peak systolic velocity. And for the arteries in your brain, the internal carotid arteries, they are low resistance arteries. So you're going to have a good peak systolic upstroke, but you're going to have low resistance waveform. So you're going to have like high diastole because the flow is going smoothly to your brain. When you have the focal stenosis, you're going to increase the velocity at that level. So again, 125, 125 to 130, greater than 230. When you have a more proximal stenosis, suppose you have an stenosis at the origin of the internal carotid, the common carotid artery in your aortic arch. The common carotid artery, the internal carotid artery, proximal, mid, and distal, might show normal velocity, but they will show blunting of the systolic upstroke. They will show something that when it's very, very severe, we'll call tardus parvus waveform. So you barely have systolic upstroke, and the systolic wave is similar to the diastolic wave. So it's very blunted, almost like flattened. And that's when you have severe proximal stenosis. So you are having an stenosis at the origin of the common carotid artery. For these cases, you want to do a CT angio of your head and neck or an MRI angio of your head and neck. For example, you are checking your vertebral artery. The vertebral artery, again, goes to your brain, is a low resistance waveform, but it has a good systolic upstroke. When you have subclavian artery stenosis, the vertebral artery comes from the subclavian artery. When you have subclavian artery stenosis, you are going to have reversal of flow in the vertebral artery, and also you could have decreased velocity and tardus parvus waveform because the significant stenosis was more proximal, okay? When the stenosis is more distal, so it's harder for me to pass. If it's harder for me to pass, I am going to increase the velocity. And I am also change from low resistance waveform to high resistance waveform, right? So the radiologist can see it very well. And we could say, hey, this is a post-stenotic turbulence, or this is because there is more stenosis distally, or it's blunted tardus parvus and decreased or normal velocity, but there is a more proximal problem that we have to evaluate. For the transcranial Doppler, we evaluate the middle cerebral artery the majority of times, and the anterior cerebral artery and the posterior cerebral artery. Again, it's not only velocity. We are looking at the waveform pattern because, again, it could be with low resistance or high resistance, and the low resistance would be the tardus parvus again, and the high resistance is decreased diastole, and also the direction of flow, if it's flowing in the direction it's supposed to be, or if it's reversed flow. Like when you have reversal of flow in the ophthalmic artery, that means you are having increased pressure somewhere in your brain. It could be from vasospasm, like subarachnoid hemorrhage. It could be from small vessel ischemic disease, so microvascular disease. It could be for any other reason that is causing intracranial pressure. Maybe the person has hydrocephalus or has a tumor or something like that, right? So it's not only velocity, but the waveform pattern and the direction, if it's normal or if it's reversal. For transcranial Doppler, I'm going to look at the velocities in my chart because I usually use my own report template. So again, for the middle cerebral artery, the radiologist consider normal when it's 30 to 80. For the anterior cerebral, 30 to 60 centimeters per second. Same for the posterior cerebral, 30 to 60. And the vertebral and the basilar around 20 to 50 or 20 to 60 centimeters per second. There's no need to know these velocities by heart. Like I said, I have my own chart when I am reading my exams. What is important to know, again, is that the parameter should not, that giving a report should not only be based in one criteria only, right? And again, abnormal, if in the middle cerebral artery, it's greater than 120, it's mild vasospasm, greater than 160, moderate, greater than 200 centimeters, severe. It is very important, particularly in patients who had subarachnoid hemorrhage and you are monitoring cerebral perfusion, because if the brain starts to increase resistance, that means the blood to the brain is poor. It's hypoperfusion, right? So in that case, you have to intervene faster. You have to intervene faster in treating the subarachnoid hemorrhage. And one good thing that we use is the Lindegaard ratio, which is, again, the middle cerebral artery divided by the internal carotid artery. Why? Because when the Lindegaard ratio is normal, less than 3, the increased velocity that we are seeing could be due to hyperemia, not vasospasm. So I'm not having increased velocity because I have increased resistance, which is the vasospasm. I'm having increased velocity because I'm having way more flow coming to the brain. And that could be when you exercise, that could be when you have a fever, that could be when you have anemia or anemic states. And when you have vasospasm, which means the velocity in the middle cerebral artery is high, and when you divide by the ICA, it's greater, it's in between 3 to 6, mild to moderate vasospasm, greater than 6, severe vasospasm. Again, that's important because it indicates like more aggressive treatment that might be needed at that time.
So I know all these kind of overlap, and you've talked about them all interchangeable. We talked about mean flow velocity. Talk about the PI. What that is,
Yes.
the blood flow, because these are the criteria that you use, and even though they're all intertwined together, but talk about that because just to make it easier for the audience.
Yes, and it's really great that you are bringing all the parameters that are evaluated because, like I said, it's not about one criteria, one parameter only. You have to put all of them together, right? For example, just to be fast here, what is more dangerous? Having a plaque, a calcified plaque that is greater than 70% stenosis that would go for revascularization, or having a 50 to 69% stenosis, which is not considered that significant, but having a soft tissue ulcerated plaque. The most dangerous would be the soft tissue ulcerated plaque with risk for emboli, while the other one is more stable. So all the things should need to be evaluated together. The PI is the pulsatility index, is the difference between the peak systolic velocity minus the end diastolic velocity. And then you divide by the mean velocity. So when the PI is elevated, it means you have elevated resistance. So elevated resistance could be, again, intracranial pressure for different situations, and in this case, is most likely you want to have
when
a
you
brain
say
MRI.
elevated resistance, you're saying elevated resistance to blood flow. The blood
Yes.
flow. Yes.
Yes. Elevated when the PI is elevated, it means that it has been really hard for the blood to flow in your brain. So elevated resistance to blood flow. Elevated resistance in your blood flow to the brain decreases the brain perfusion. And it could be because of microvascular disease, which is related to diabetes, hypertension, right, inflammation. It could be to subarachnoid hemorrhage, and then you follow with the Lindegard ratio, and you follow with the velocities to define what kind of treatment might be needed. It could be due to increased intracranial pressure. That could be a tumor. So then you're going to have another exam like an MRI to see if there's something giving mass effect in your brain. So that's the PI, mainly when it's increased. When it's decreased, which means you have decreased resistance to blood flow. So the brain is having a lot of blood flow. It could be, again, because of the hyperemia, which could be exercise, fever, anemia, or could be because of loss of autoregulation of flow. In these cases, when the brain is not autoregulating, we do another test, which is the transcranial Doppler with increase in CO2, like the person inhales and stops breathing. Increasing in CO2 is supposed increase
Dilate the blood vessels.
Dilate the blood vessels, so it's going to increase the flow. So if it doesn't happen,
and they ask the patient to hold their breath for about 30 seconds. Is that correct?
Yes. And if it doesn't happen, if it doesn't increase the blood flow, what does that mean? That your brain is losing the capacity of autoregulation on the blood flow, the brain perfusion under stress or under any circumstance that is leading to vascular dysfunction and vascular injury.
Now let's talk about the next one, direction of blood flow. What
Yes.
would the blood flow go in the wrong direction?
Yes. So if the blood flow goes in the wrong direction, that means for example, a reversal of flow in the ophthalmic artery, that means the blood is not being able to move forward. So it's reversing, which is most likely because there is something forward that has a lot of pressure, a lot of resistance, that that vessel is not being able to move against it. So it could be severe vasospasm from subarachnoid hemorrhage. It could be severe intracranial pressure from different causes. It could be significant microvascular disease, which is associated with diabetes, hypertension, inflammation. And yes, it could be due to a vessel occlusion. For example, you had an emboli or a thrombus that came from atrial fibrillation or an unstable plaque and occluded that vessel distally. So then the blood is not moving forward, right? So definitely it's an indicative of major risk for stroke. And then you evaluate the other vessels around to see if the brain is autoregulating by building collateral circulation. For example, when the blood flow reverses in the ophthalmic artery, the brain might ask the help from the external carotid artery to bring flow to the brain in another way, which is when we get the circle of Willis connecting all these arteries, right? The anterior cerebral artery, posterior cerebral artery, middle cerebral artery, vertebral arteries, basilar artery, and the communicating arteries that are there for helping in the collateral circulation when needed.
And the next one is emboli detection, which you talked about the hits.
Yes.
So the high intensity transient signals.
Yes.
So that's an easy one to understand because we see if there's any kind of particles flowing through, and then the technician could hear noises, these
yes,
chirping noises.
Chirps, whistles, or pings. So again, when you are listening, the transcranial Doppler is a listening exam, right? Is a pulsed Doppler. So when you are listening to the blood flow, it's almost like when you were listening to the heartbeat of your baby, right? When you were pregnant, you are listening, right? So it's a constant, it's the same pattern, it's the same sound, right? So suddenly you are listening to a normal sound, and then you like ping or chirp, and then it's like when you have a high intensity flow, a high velocity event because of the emboli or the particle or air bubbles or clots that detached from another area in your body, either the carotid or the aorta or the heart or a surgical procedure, right? So they detach and they are passing through that vessel in the brain in a live moment. So you are detecting live emboli, live microemboli. So again, it is high intensity transient signal, and there are criteria for detection. They must be brief. They must have a specific amount of velocity and noise, and they are very predictive, very significant factors for stroke risk, because each one of these emboli at some point might occlude a vessel, right? Depending on the particle size. And when they occlude the vessel, you could have a major stroke. In fact, microembolies are microstrokes. Like the small vessel ischemic disease we have in the white matter, they are called sometimes, some of them become lacunar infarcts. So again, they are inflammation, endothelial dysfunction, and the microemboli lead to microstrokes. And when they are most significant, they lead to significant stroke. And the small vessel ischemic disease has been correlated with, is called vascular dementia, because it can definitely impact your memory, your cognition, your speech, and your balance. Different from Alzheimer's, but also a dementia.
Now, does the radiologist hear the sounds from the emboli, or are you relying on the radiology technician?
I do rely on the sonographer technician, yes. Here in the United States, I don't know, when I was at the University of Minnesota, we always had sonographer technicians doing these exams, and they are very well trained. They need to go through a vascular lab preparation. Yeah, but the sonographer technologists describe everything for us, and we describe the results. When there is any question from the sonographer technologist, they call the radiologist who is on site, and we go and we review and we do the exam together with the sonographer technologist. But usually when we are following patients who had subarachnoid hemorrhage and are dealing with vasospasm, it's done daily, right? To see the evolution, to not lose any worsening in the window of treatment. So it's the sonographer technologist, yes.
So they don't call the radiologist and say, listen, I think I'm hearing a whistling. Do you agree? And then they have you listen.
Yes, either they have you listen, or in general, the radiologist go to the bedside, or the radiologist goes to the room that the exam is being done. And that's usually how it's done. We get out from where we are and we go where the exam is being performed, and we are there in person, following through, and even performing the exam again as well.
So we're talking about key parameters for transcranial Doppler. And we
Mm-hmm.
the first four: velocity, pulsatory index, which is resistance, directional flow, is the blood going in the right direction, are the little plaques or emboli. The last one is vasomotor reactivity. And that's the one that you talked about, where the patient will hold their breath and to see if their blood vessels are dilating properly. And you kind of explained that, but just a quick explanation again, if the blood vessels are already dilated, what does that mean? And what do we want on that? We want them to dilate, but if they're already dilated, that means that there could be a problem.
I don't do that very often, but I usually they do these exams when there is asymmetric flow in one artery to the other. So then you do the buildup of CO2 by holding your breath 30 seconds, and it's supposed to increase the velocity in 30 to 50% in one side or the other side. And you compare. You compare to see if there is asymmetric. Usually you have impaired vasoregulation. Again, if the vasospasm in one side is really, for example, subarachnoid hemorrhage follow-up, right? If the subarachnoid hemorrhage is worse in the left side has a more severe vasospasm. So the CO2, it's not really going to dilate that MCA the same way it's dilating the right one, right? So that's another criteria that we could add to say, yes, it's not really responding, it's getting worse, it's progressing, and then you should act on that side. Yes.
So
I hope it helped, it answered, because I really,
yes.
yeah.
Before you talked about if there was a problem that they would go in and do revascularization.
Yes.
What is that?
So revascularization, for example, you have a plaque in your internal carotid artery that is calcified, and you have a greater than or equal 70% stenosis. So that patient is at risk for a stroke. So after that person is evaluated for the vascular surgeon or the interventional radiologist doctor, they decide together with the patient if he or she is a good candidate. And then they are gonna, either they could do endarterectomy, which is removing the calcified plaque with the equipment that they have. And if needed, they can do stent, they could put a stent as well, right? So it's endarterectomy with a stent, which is a tool. I don't know what, that is going to open the vessel and it's going to keep it open. And you do that. They do that a lot too for the lower extremities that usually build up calcium a lot, and the people are having difficulty walking, very much painful, and then they go and they do the endarterectomy, cleaning the plaque, and then adding a stent to prevent it from narrowing again. However, there is a risk for building plaque and narrowing the stent later on as well. Hence, we have different criteria to evaluate carotid stents and arterial stents in the legs, a different velocity criteria for each ones.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.